This is, again, Daniel Raymond with National Viral Hepatitis Roundtable. And we have a little bit of time just to try to start to imagine weaving some of these threads together. And I think when we started planning this, we all said, you know what, everybody knows about the challenges. We've got to talk about the strategies. We've got to talk about the solutions. And I think what I heard over the past couple of days is that in these key settings, we have proof of concept, maybe proof of principle that hepatitis C integration of testing and treatment can happen, but that we have this kind of dance or salsa or zigzag back and forth between the solutions and the challenges, and that I talked about weaving some of these threads together, but in some cases it's about unknotting some of the barriers. And we've heard some creative ideas, some promising practices. So we've invited a moderator from each of the four panels to share some just top line overall highlights or reflections from their panels so that we can start putting those jigsaw pieces together. And so I'm going to start with my co-moderator from the Medications for Opioid Use Disorder panel, Dee Bixler, to kick us off.
All right, thank you very much, Daniel, and thanks to everybody for sticking around to the bitter end here. Our panel was on treatment of hepatitis C in clinics where medication for opioid use disorder is offered, and we got a lot of really great ideas from our panel, and I put them into three major buckets. The first bucket is just having the importance of having a multidisciplinary care team that practices compassion, confidential, patient-centered care so that patients feel safe and protected. That seemed to be a core issue that came up. The second bucket seems to be having sort of a streamlined, standardized assessment and treatment protocol so that patients can fit in at any point when they arrive at the care site. So this would include opt-out testing for hepatitis B, HIV, and hepatitis C, reflex to RNA, and reflex to Fib4, so that everything is done in one blood draw. Same-day medication start, and then because you have this standard protocol, patient care can be initiated at any point where the patient arrives for care. So if they arrive with a positive antibody, you can just put them right into the protocol. Third bucket, meeting patients and providers where they are. So this includes low threshold walk-in services, transportation, and again, that ability to initiate patient care from any point in the protocol. Now, to roll things out nationally, here's what I heard people say is needed. A point-of-care RNA test, starting to sound familiar. Removal of all prior authorizations so that medication can be stored on site and started right after the treatment results are available. No limitations on retreatment and co-located services, especially, as Dr. Martinez called it, the trifecta: hepatitis C treatment, harm reduction services, medication for opioid use disorder. Finally, our providers were very emphatic that our current reimbursement system provides lots of perverse incentives that really interfere with effective patient care. And so as we think about next steps, we have really got to think about this system and how to address it. And one last thing, there was a lot of discussion about the state of medication for opioid use disorder treatment in the United States. I'm going to provide a resource. There was a different convening that was done about a year ago that had some really thoughtful discussion about this and some excellent proposed solutions. And I'll put that in the chat for everybody. Thank you so much.
Thank you so much, Dee. I appreciate those highlights. Next, we're going to just do some quick reflections on our panel about state corrections. And for this, I will turn it over to my coworker, Adrienne Simmons.
Thanks, Daniel, and thanks everyone for sticking around today, and special thanks to our speakers. You all have heard that there are a lot of complexities when it comes to providing healthcare in places where it isn't traditionally provided, and state prisons are no exception to that. So yesterday you heard about all of the challenges, clinical, financial, operational, as it relates to hepatitis C care in prisons. And all of that is, of course, set against the backdrop of unmet social needs, systemic issues like poverty, racism, and a broken healthcare system. But we heard a lot of success stories as well from states across the country who have figured out how to make this work. While much of this work has been catalyzed by legal action, as we all know, hepatitis C won't wait for litigation. And so I'll highlight just a few considerations for implementing and scaling up programs based on what we heard yesterday. First and foremost, relationship building and support from a variety of different stakeholders is really critical to implementing a successful Hep C program in correctional facilities. This includes getting buy-in from correctional facility leaders and government, listening to and leading, following the lead of people who are incarcerated, and then finally identifying experts and champions who can support facilities in navigating the clinical, financial, and operational nuances of providing healthcare in prisons. Building data systems is also really important. So generating care cascades takes a lot of time and effort and coordination with health departments, ensuring that we're collecting the appropriate lab information. But it's really essential for us to be able to track our progress towards elimination and to do quality improvement work. And then finally, it was mentioned that we can't treat our way out of our hepatitis C crisis. It's really important to establish and scale harm reduction services in prisons, including medication for opioid use disorder, as well as providing access to sterile equipment for things like safe tattooing and substance use. And so I'll just wrap up by highlighting a few examples of current practices as well as future opportunities that will move us closer to eliminating hepatitis C among people who are incarcerated. So in thinking about financial barriers, we've heard that lots of programs have successfully utilized things like the 340B program, as well as innovative payment models to reduce costs. The proposed National Hepatitis C Elimination Program is another potential avenue to address financial barriers. And we also heard some discussion about how Medicaid 1115 waivers might provide another opportunity to pay for care in the months leading up to a person's release. From a clinical and operational standpoint, peer education programs have played a really important role in both disseminating important health information among people who are incarcerated, but those programs also have immense and tangible value when it comes to relationship and skill building for people who are incarcerated. And then finally, transitions of care for people who are re-entering the community continues to be difficult. And so re-entry and transition programs can really help reduce the number of people who are lost to follow-up, as well as decrease the risk of reinfection. And again, Medicaid 1115 waivers might present an opportunity to help with transitions as well. That's all from our group.
Thank you, Adrienne. And for federally qualified health centers, I will turn it over to Mona.
Thank you, Daniel. Okay, I really want to thank and reiterate our speakers and subject matter experts who took the time to really showcase so eloquently some of the successes and barriers in delivering HCV care in FQHCs. So a few takeaways from the FQHC session was there was a lot of discussion on evidence-based and promising practices. We heard about the optimal HCV care models on integration with primary care services, harm reduction, patient navigation, street outreach, and the use of mobile units for linkage to care. In addition, there was a discussion on the value of universal screening, routine opt-out, HCV screening, the need for the point-of-care RNA testing, the importance of patient navigation in overcoming stigma and care coordination, the importance of leveraging EMR prompts and standardizing them. There was also a discussion on data sharing with other partner organizations to improve the continuity of care, and the importance of integrating services within FQHCs as a one-stop shop for online on-site lab services, MOUDs, mail order pharmacy delivery for medications, and also discussed using the importance of a syndemic approach and partnerships with the HIV program to fund testing, transportation, and patient navigation and incentives for patient care. Some of the needs and barriers that were identified, there was a need to increase the primary care workforce and an increased provider knowledge to treat hepatitis C. A lot of times it came up in the discussion that more grants are needed to fund for more staffing, patient navigators, and providers for operations. Integrating hepatitis C in primary care services needs more time, as there are competing provider and patient priorities was another issue that was discussed. They also discussed the importance of removal of prior authorizations, as there are some jurisdictions who are still having some restrictions. There was a need to expand telemedicine services, and they were unsure if it was here to stay. One unresolved issue discussed was the cost of lab tests and visits for uninsured patients. And they also, there was a need discussed to create a technical assistance guide on how to effectively integrate testing and linkage to care workflows at each site. And finally, a key message throughout the whole presentation was working with the community to identify champions, building trust, building community partnerships, and leveraging partnerships with state and local health departments, working with the primary care associations, and partnering with pharmaceutical companies, nonprofit agencies, and jails. So really, really great session. Thank you.
Thank you so much, Mona. And now, having had a full 10 minutes to digest and synthesize a 90-minute panel, Talia, what would you like us to remember and retain about SSPs?
So much. So I think, just starting with some key points that I really want to highlight here, and obviously there were many important points. So we had quite a lot of discussion about opt-out Hep C testing and the importance of bundling HIV and Hep C testing, and how that's especially effective in an SSP setting. We had a conversation about peer navigators and how important it is to utilize people with lived experience and pay them well, especially in the SSP setting, both for building trust among SSP participants, but also for just engagement and know-how and knowing where people are, that there's really a bountiful amount of benefit of having people with lived experience on board and paying them well. And that, I think, sort of leads into the patient navigator role, including care coordination, which I think there was a lot of conversation about how peer navigators really support SSP participants in getting the services they need, especially when services are not provided on site. And examples of that, multiple people talked about supporting people, escorting them to get off-site lab services when phlebotomy wasn't available on site. Telehealth was discussed, paired with peer navigator as the ambassador to the provider. Multiple examples of telehealth models and teleharm reduction models. In terms of the co-located care, this is a topic that we're hearing from all the settings, really, but really the importance, especially within an SSP, to be able to provide multiple services, not just one, and partner whenever possible, but really the benefit of having multiple services available to meet the different priorities of SSP participants and meeting them where they're at, which could be related to housing, could be related to food, could be related to something having nothing to do with Hep C, but recognizing that's part of a model to scale up. Finally, incentives, or not finally, continuing, there was a lot of conversation about the value of incentives, even if small, and also the value of having wraparound services, like I mentioned before, including also transportation and supporting participants in whether that be through bus passes or other modes. I wanted to also mention the conversation about stigma and how much of a barrier that is in participants receiving care. Stigma, whether that be perceived stigma and in terms of how Hep C or HIV testing is offered, and recognizing that when it's as an opt-out model is less stigmatizing. You know, and I think also the conversation about providers, participants not having trust in providers and being and not wanting to even begin that relationship because of concern of how they'll be treated and lack of trust, and the importance of providers being trained in harm reduction and knowing how to have those conversations and work in an environment that is loving and welcoming to SSP participants. We talked about the collection of data, lots and lots of data becoming being a barrier to providing services, even in something as simple as having additional questions might be a reason why an SSP participant decides not to engage in care. So recognizing that that's an important barrier. We also talked about mobile testing and the role of having a mobile unit, and also, you know, related to that, having untraditional hours and incorporating telehealth potentially into mobile services when possible. So those were some of the key points. I think the important strategies for scaling up are part of that that list, or those highlights. But I guess the one thing that I wanted to sort of end on is the emphasis on making testing and treatment as patient-centered as possible, which we heard time and time again, and recognizing the role of multiple staff in the care of SP participants and in providing their services and valuing those staff. And I will end there.
Thank you so much, Talia. I just wanted to invite Nate to share his reflections as well.
Thanks, Daniel. Yeah, no, this has been a phenomenal 2 days and 4 panels. It's a bit of a blur to me that just all the amount of information that we've received, and I think it's a little difficult to absorb all at once, but some common themes that kind of 3 things stuck out to me. The first was just, you know, hearing that although we've made a lot of progress in making testing and treatment a lot more simple, I just heard over and over, there's still a lot more ways that we can go to make this more easy to decentralize. I think better diagnostics to allow same-day treatment algorithms, breaking down barriers to DAAs, making sure we have a workforce that can deliver compassionate care to people with hepatitis C, and then just also breaking down the barriers amongst ourselves of, you know, between these different silos that we've all talked about. It's you know, almost very different mentalities and perspectives, but everyone has something really important and unique to contribute to this whole kind of joint project that we have trying to eliminate Hep C. The second point that I really walked away with was just, gosh, hearing these 4 panels was amazing because it was so great to see all the innovation in the field by each of the different presenters and contributors. And they've really, I think, accomplished that goal of what we'd hoped to, is just show us how it can be done. And then make a compelling argument that this can be scaled. And I think I saw that vision a lot more clearly today. And it's we need more resources to make it possible, but I can see it happening. And then the third point is just, you know, on that resource piece. So despite, you know, we didn't cover it as much in my initial presentation or over the course of it, but with economic health modeling, we know that treatment for hepatitis C is one of those rare wins for everybody, where, you know, obviously the patient wins in that they have decreased morbidity and mortality from all the associated diseases with hepatitis C. It's a win for public health because there's fewer people who are going around and infecting other people, and it leads us closer to elimination. And that's actually a win for payers in that fewer people with all these liver-related complications means less healthcare expenditures. But it's bigger than any one given institution, agency, or entity that can really handle it, because this is a big problem. It's one born out of a larger syndemic that I discussed earlier. And so we really need this national approach to get us on track to reach elimination. And to that vein, I know we're currently with bated breath awaiting to hear if Congress would take up the National Hepatitis C elimination plan under consideration. And I feel like with that, the stars could certainly align, and we could certainly get on a path towards elimination. So I'm leaving this convening very hopeful, and I hope you are too.
Thank you, Nate. I believe that we will be hearing a lot more from and in Congress about their take on the prospects for a national hepatitis C elimination proposal this fall. I am confident about that. I am sometimes a bit of a Pollyanna about these things, but I know that I am committed to doing everything that I can, and I know that I speak for a lot of us here to keep moving that ball forward. I think that as I was hearing these fantastic top line syntheses, some of the kind of cross-cutting things that kept coming up, whether it's stigma or medical mistrust or homelessness or incarceration, we went really deep on a lot of these pieces. And from a different lens, we barely scratched the surface. All of those experiences are heavily inflected by poverty, race and racism, gender, sexual orientation, parenting status, immigration status, language spoken. And so I don't want to minimize the challenge before us, but I do want to echo the sense of hope that people kind of brought forward, that there are some charted paths in front of us. There are some potential roadmaps, and we hope that this convening has been another contribution towards that. We started this discussion to plan this event with a sense that we know that there's a lot going on in many parts of the country, a lot of fantastic and innovative and creative and resourceful work. And if you were a planner, if you were an implementer, if you were an advocate, where's your playbook? How can you make sure that you're learning from the best, that you're not reinventing the wheel, that you're not having to make it up as you go along? And so as a down payment on what's going to happen next, these two sessions have been recorded. Every speaker who's comfortable with us sharing their slides, we will be posting the slides, and we will be developing and disseminating a report that tries to package and synthesize all the insights from these last 2 days and from the journey that we've taken to get here. So that is our collective pledge on behalf of my colleagues at NVHR and NASTAD and our friends that have been supporting us at CDC all along, that we really feel like if we can collectively tap into the best insights that we've had the privilege of hearing and surfacing over the last 2 days, that we can move the collective ball forward and bring that ray of hope to everyone and maybe to Congress even as well. So I want to just make a small pitch before you go that we do have an evaluation form today. And again, thank all of our colleagues at NVHR, NASTAD, and CDC, and I will give the final words to Dr. Carolyn Wester.
Well, Daniel, thank you. Thank you. I know I'm gonna leave people out, but I'm just gonna say everybody on here, you're on my list. Daniel, Adrian, Jasmine, Nate, Dee, Mona, Talia, all of our presenters, and of course, the participants too. This has been extraordinarily rich. The Q&A, the chat has been incredibly robust and informative. This convening, as Nate has mentioned, and several of you as well, is incredibly timely. We have a strategic plan, we have elimination goals, and for the first time, we have the highest levels of government championing championing a national hepatitis C elimination program. And if this is funded by Congress, it would provide for the first time the resources that we need once and for all to get the job done. So the presentations at this convening not only provide insights into the foundational ingredients of exemplary programs that are operating in the key settings that we've addressed, but they also inspire us not only to replicate these models and key settings with existing resources, but provide insights into the areas of highest priority for implementation as resources become available. And again, I just want to thank you for the tremendous Q&A sessions, the questions asked, and the ideas and resources shared were really very, very rich. The kind of high points and takeaways, I think, have been very well summarized, and we're obviously going to get a full meeting report. So I'm going to skip over all of my insights into that right now, because I think you guys really nailed it. But I just wanted to let you know how inspired and grateful I am for the work that you guys lead, everybody, and the commitment to providing patient-centered care in all of these key settings. So I share your optimism that we are not only making progress, but that we have tremendous opportunity ahead. And I want to sincerely thank you, not only for your engagement in this convening, but also for really all the work that you do unceremoniously on a daily basis to really promote patient-centered care in all of these settings. So thank you very, very much.